All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic is caring for the aging and advanced illness carceral population. And we are honored to have our distinguished guest, Dr. Susan Loeb, who is a professor of nursing and medicine at the Ross and Carol Neese College of Nursing at the Pennsylvania State University. She is an established and well-known expert in the care of the aging and the advanced illness carceral population, and she even has links to some of us here in Milwaukee, having taught at Concordia University in Mequon, Wisconsin. So our format for today is going to be a short and sweet presentation. We'll have a few minutes at the end for some audience questions. And with that, Susan, welcome and thank you. And I will hand the mic over to you.
And thank you, Marty, and thanks for having me today. And I appreciate the folks that have made time out of their busy day to join us. My objectives for us for today are threefold. That at the end of the presentation, you'll be able to list a couple of reasons why enhancing care of people who are incarcerated, older, and living with advanced chronic conditions are in need of better care and consideration than they're oftentimes able to receive within carceral settings. Describe the focus of my team's current e-learning program, which we have recently transitioned from the label of inmates care to just care to avoid pejorative language and negative labeling of our population of focus. And then I'd like you, and this is probably my most important goal, to consider one potential application of what you've learned today in your current or future practice, community service, or research endeavors. So I'm going to provide you a few slides at first here, just giving you some important foundational information. People 55 and older now make up 5 times as much of the prison population as they did just 3 decades ago. And not surprisingly, this older population who's incarcerated are the highest consumers of prison healthcare resources. Unfortunately, every 2 years that someone spends in prison is estimated to take 2 years off of their life expectancy. Prison is not a nice place to be, and especially not a nice place to grow old. Prisons were not built with the older and infirmed adult in mind, but yet rather for a younger, vigorous, more rambunctious population. And as the demographic shift has occurred in the free world, largely due to the baby boomers, that so has it within prisons, as prisons are microcosms of our broader society. Healthcare resources in many prisons have been described, especially by the Prison Policy Initiative and recently, as being both ineffective and exorbitantly expensive. And you've heard me initially bring up the population 55 and older. People 50 or 55 and older are typically who are being described when you hear of older adults in prison, because when you're incarcerated, especially for extended periods of time, folks tend to appear and have chronic conditions where their aging has advanced physiologically much faster than it has chronologically. So a 50-year-old in prison who's been incarcerated for quite a while probably is going to look more on par or have a disease profile more on par with a 65-year-old or at least 60-year-old outside of prison. And there's always exceptions, but also, on a global level, this growing older population in prisons is not limited to the US. The literature is replete with examples from Australia, the UK, and even Africa and other developing nations where prison populations are being represented more and more by an older population. So although we don't have comprehensive information on older adult in prisons globally, what we do know is that over across the world, growing numbers of people are growing old and actually spending their final days, hours, minutes in prison. Palliative care is a pressing need, which in many cases remains left unmet, always exceptions to the rule, and trailblazing prisons. Trailblazing prison hospices you've probably been hearing about since the late 80s and early 90s from the Grace Project onward. But in general, it's still loads of room for improvement. The COVID-19 pandemic further challenged correctional systems because, akin to nursing homes, just the pandemic hit those so hard, for myriad reasons, most high on the list being the close quarters that folks live in together, the difficulty with isolating folks from someone else. And when they do isolate them, then they may be in segregated housing, which has been described as inhumane and not good for mental health. Researchers couldn't come in and out of prisons, but more importantly, any outsiders that were not necessary for the day-to-day operations of the prisons were put on hiatus, and that includes family and friend visitations, which are really important to the mental and physical well-being of those incarcerated. Zoom and other sorts of video conferences did come to the fore, which was a plus, and folks weren't charged for their phone calls typically during pandemic. However, we've gone back to charging, and with this emergence of the video conferencing and the like, there's companies that really take advantage of the situation, and systems, obviously appreciate in some respects the convenience and less security considerations with video conferencing, but it isn't the same. And then when it's falling on, the expenses falling on the shoulders of folks in prison that make anywhere from maybe 14 cents to $1 an hour, or their families, which oftentimes are not rich in financial resources, that the ethics of this has come to the forefront in publications by advocacy groups and the like. I'm sure you have read in the news and major newspapers about compassionate release or medical parole or some other term used to describe that. It's often discussed, yet unfortunately rarely actualized alternative. And so one of the questions from the audience, which Marty was kind enough to collect prior to my session today, was, what does this term compassionate release mean? And it actually refers to the authorization of the court to reduce a defendant's term of imprisonment for quote unquote extraordinary and compelling reasons. And as you can imagine, during the COVID-19 pandemic, requests for compassionate release, because of the high risk of folks who are older and with chronic conditions for severe COVID, really increased. The good news is that the compassionate release rates were granted more frequently than usual, and the estimate that I saw was about 7% were granted in that time period between October 9th, 2019 and September of 2020. However, post-COVID, if that's an okay concept to use, rates dropped dramatically since then. Factors that contributed to that 7% who were released were greater age, longer length of sentence, and greater percentage of time served. That really increased their likelihood of having a compassionate release granted. Another challenge is that many prison staff have not been trained in managing and caring for older adults. The physician workforce and provider workforce in prisons, some may have had specialty background or cared for an abundance of older adults, say in an internal medicine or family practice setting. But you have folks who were OBGYNs in their field before they went into corrections health, or were maybe an anesthesiologist. I'm just thinking of some examples of folks that I've encountered. So many don't come with that particular specialty skill set. You'll have some nurses who worked in long-term care, which certainly is a plus. I've worked with a nurse who was a hospice nurse, infectious, disease nurse in the free world first. Those bring more skills in this area, but again, the specialty practice is largely limited to telehealth. And typically isn't geriatrics, but more things like oncology, dermatology, some of those specialties that are prioritized and tapped into more frequently. The other thing to bring to the fore is this abundant human resource of folks who are living in prison and incarcerated. And myself, as well as others, have contributed to the body of research evidence that supports the use of peer caregivers to assist staff with care in prisons. You may have seen some documentaries about, say, the Angola Penitentiary in Angola, Louisiana, the Louisiana State Penitentiary, and the prison hospice there. It was one of the early ones. You may have seen, I think there's one on the California Medical Facility in Vacaville that's probably out on YouTube. And I actually am providing a link to one from about 2014 later in the presentation, if anybody wants to watch that on their own time or share it with others. The bad news about peer caregiver training is that it varies widely from prison to prison. Typically it's homegrown content, not necessarily evidence-based. Doesn't mean it's bad, but it's not standardized. It's highly variable also in terms of duration. And you know, there's not consistency and the necessarily staying up to date, and have the best practices actually been adapted for the culture and context and restraints of prisons. And that's what my team has been really heavily focused on since probably about 2015. The other unique situation about corrections, although you may have a security officer in a hospital or in a large major medical center, more than one, but you don't see this interaction between the healthcare team and the security team like you do in prison. And so there's no neat division between care and custody. The tripartite mission in most prisons is care, custody, and control. However, in prisons, corrections officers must stay ever vigilant for emerging care needs of those on their housing units or cell blocks, out in the prison yard, or, you know, even in the infirmary. Prisons were not built with older adults in mind, and this image really brings to mind this fella has vision impairment, looks a little bit bewildered. You see steps in the background. If you went into a particular cell, you would have bunk beds, and there's no guarantee that the older fellow will get the bottom bunk. And so you could have someone fairly disabled being relegated to the top bunk, either by assignment or in practicality, because they have a younger, more vigorous person intimidating them who has relegated them to that. So it's not a nice situation for older or sicker people. At the same time, the corrections officers have to be vigilant for emerging healthcare needs. Corrections nurses need to be ever vigilant for safety and security needs. And not just nurses, but I bring them up in particular because they're the ones that are going to have the most face-to-face contact and, you know, hour-to-hour, minute-to-minute care of people, both within the infirmary or prison hospice, if there is one, or even out on the housing units. This is just a phenomenon that's important to bring out. I thought a really nice way to bring this to life is, and I've not seen this conference before, but in February of this year, they're actually having a joint conference between the National Commission on Corrections Healthcare, which I've been to many times, large number of physicians in that organization, as well as nurses, psychologists, licensed clinical social workers, and others, pharmacy, with an actual custody organization here, the American Jail Association. So I thought this was pretty cool to show how they're recognizing the importance of bringing these folks together in a educational kind of environment, because there can be, you know, several challenges, a conflict because of different priorities and different people thinking they have authorization over, you know, what's done in healthcare than actually should, or dual loyalties. There's a lot of problems within corrections healthcare with the care recipients and not having trust in their healthcare providers, because they see that the healthcare providers, by nature of where they're working, have some security responsibilities, which makes them worry that they don't have their best interests at heart. So very unique situation and unique challenges. Which leads me into another question that was posed to Marty, which was, what can we do to help this population? Is there an opportunity for activism, volunteerism, education, or even something else? So I just sought out a few examples of things and resources that I thought you might be interested in terms of volunteer opportunities. There's the Medical Justice Alliance, which is out of New York City, and you could look into, if you're from that general vicinity, look into what the opportunities are there. The Federal Bureau of Prisons also had a recent posting online, an inside look at volunteering with the Bureau of Prisons. In terms of activism, the prison policy initiatives, which I have cited a couple of times already, they put out great reports and sort of the state of the demographics, the state of care, good things that are going on, troubling things that are going on, and very active. And the Academic Consortium on Criminal Justice Health, again, very interdisciplinary. Most of the leaders of that organization have been physicians in my memory, but lots of nurses, again, licensed clinical social workers and different disciplines. And educationally, this academic consortium also puts on an annual conference, which is the Academic and Health Policy Conference on Criminal Justice Health. And then the National Commission on Corrections Healthcare, very educationally focused. They do accreditation of all kinds of healthcare providers in prison, where they become NCCHC certified corrections professionals. And so that's for medicine, nursing, and the others as well. There's a physician solely based organization called the American College of Correctional Physicians, which have not gone to that conference. I really focus on the NCCHC and then the criminal justice one. So, but there's current links. NCCHC actually offers 2 standard medical conferences a year, one in the spring, one in the fall, and then every summer offers a corrections mental health. And I've been to all of those, and they're all excellent, as is the more policy-driven group, the Academic Consortium. The other thing that this is sort of a bit of a call to action to you all, but exposing medical students and residents to this area of specialty practice. I mean, even going for a tour and seeing what those infirmaries look like, speaking with corrections physicians and other healthcare professionals, I think could be tremendously helpful. In my small town in central Pennsylvania, that is the size it is because of our huge university and a popular football team, has 2 state correctional institutions within a couple miles of the university, and they're large. And one of them recently opened a neurocognitive care unit, and they welcomed me to bring students with me in to tour those. And our undergraduate community health faculty, as well as our DNP and P students, have used those sites for clinicals as well. The NPs are far more hands-on. The undergrads are there for maybe a 4-week rotation or something, a little bit more observational, but they do some hands-on. But and there's a lot of nurse practitioners in correctional systems as well, as physicians, and not lots, but there's a good representation of them there. There was a documentary came out on the Iowa State Penitentiary's hospice end of life program back in the mid-teens, and it actually was put up for an Oscar. It was an Oscar nominee in 2014. It's a little bit dated now, but it's still quite good. And I think if you wanted to get a nice snapshot that's an hour or less, it's very well done. Edgar Behrens is, he's done a couple of documentaries on prisons, and has a real nice perspective on it, and brings people to life with their experiences. So I'd highly suggest that. Just wanted to take a few minutes to share with you what my team and I have been doing. One of the 2 studies we have now is called Just Care, and we're conducting research and development on a 6-module e-learning program for peer caregivers in prison, and a single module to direct corrections staff in launching and leading a program. This is just a picture of my research colleagues. At the top of the right panel, Barbara Walkos is a communications research scientist and former professor and department head at the University of Colorado. And then you can see myself and my team on the left. Just want to acknowledge the NIH, NIA for funding our 2 current studies, and giving the caveat that this presentation is solely my responsibility and does not necessarily represent the official views of the NIH and NIA, and I have no conflicts of interest. And I just want to show you a really brief intro to our training.
Welcome to the Just Care training. This program is a collaboration between Penn State Ross and Carol Neese College of Nursing and Klein Bundel. The designers built this training with a passion for the care of people who are growing old, living with advanced chronic health conditions, and approaching their end of life. We believe that all human beings deserve respect, dignity, and compassion. In this training, you will learn about chronic conditions and end-of-life care, and how to detect and address issues related to aging, loss, grief, and bereavement. You will learn how to put strategies to work to enhance the care of the growing numbers of older and sicker people who are incarcerated in your setting. Additionally, you will learn how to manage personal stress that arises from taking care of older people who are incarcerated by engaging in self-care. Now, let's go through some of the functions and features of the program. Since you have successfully registered for the Just Care training, you may log in at any time using your identification number and unique password that you created in registration. Simply type your identification number as the username and your unique password on the login page and click Submit. After logging in, you will see the home page and a light blue menu on the right-hand side. This right-hand menu contains the program's modules. There are 6 modules in the Just Care training. The user icon on the top right corner of every page gives access to the home page, profile page, as well as the log out button. You will begin with the first module, the foundations of effective caregiving, and end with managing stress and engaging in self-care, completing the modules in order. You will be asked to complete a short quiz before each module. You may not know the answers, and that is okay, because you will not be scored on this pretest. Answer to the best of your abilities. You will eventually learn about these topics. Once you enter a module, there are additional features to the program. To go back to a previous page, you can simply navigate the right-hand menu and click on that specific page to view it. The Continue button appears automatically on text pages. However, on pages with activities, you must complete the activity before the Continue button appears. Once you click on the Continue button, you will be moved to the next page in the program. There are videos throughout this program. To begin a video, press the play button. To pause the video, press the pause button. You can turn on closed captioning. You will also have the option to replay a video once it is finished. At the end of each module, you will need to answer quiz questions. You will need to get at least 80% of the questions correct to pass. You will receive 2 more attempts to pass before you will be directed to the beginning of the module to review the content. You will have a new opportunity to take the quiz again. Your score for each attempt will be visible after you submit your answers. You will be required to sign in and sign out of the program with every session. To sign out of the program, click the user icon in the top right corner and the Log Out button in the drop-down menu. Make sure you sign out at the end of your session so that your progress within the program is saved. Anytime you sign in, you will start where you last left off. One more important detail. This training is not specific to your facility. It was designed to be used at different types of corrections facilities that may have different policies than your facility. Some of the content may not be relevant to you, your work as a caregiver, or your facility. Remember to always follow your facility's protocols and to ask your supervisor for clarification. Thank you for watching this tutorial. You are now ready to begin the training.
Core values, my colleague Steve just noted what they were. I just wanted to say that they were developed in collaboration with both people who are incarcerated and staff in corrections, as well as our Blue Ribbon Advisory Board panel from across the U.S. Now we come to question 3 that was posed by one of the audience members. What types of care are peer caregivers providing? So I split these up in several different ways. Here on the first slide, I wanted to share with you, there's some hands-off duties that they contribute, helping to train new peer caregivers, helping to vet new peer caregivers, along with a panel of correction staff to be able to be determined whether they're suitable or not for the program. Providing administrative support for healthcare staff, just helping them with general duties around the infirmary, say. And providing bereavement support for the patients that they're caring for. Emotional and social support, being simply a companion, filling some of that void that family and friends and even, say, a hospice volunteer might provide in the community. Providing some diversions and social interaction through playing board games or card games. Encouraging and assisting a patient to still engage in group activities as they're able. There's also some activities that previously paired caregivers were actively engaged in, sometimes still are in some systems, sometimes are absolutely not in other systems. At or around 2003, a piece of legislation came into play called the Prison Rape Elimination Act. And it's been implemented in different ways in different institutions. Some took it as a call to ban any kind of physical contact between the folks who are incarcerated in these caregiving roles. So no more activity of daily living assistance was the biggest one. However, enough correctional systems are still engaging people in assisting staff with transfers and oral hygiene and physical care that it still warrants being in there. This was something we've put a lot of time and consideration in, and say in an advisory board of 10, 12 people, the jury's still out on, some systems are doing this and some are not any longer. Care before and after death. This has less to do with Prison Rape Elimination Act than your I guess your ethical stance on this dilemma. Is it healthy, mental health wise, to have folks who are incarcerated engage in this type of care? Does it close the loop? And again, it just varies from institution to institution. So you'll hear at the end of that introductory section there, our caveat that we always check with your supervisor, follow the policies of your institution. We're really trying to be inclusive, and a system down the road could certainly decide to include or not include a certain segment. A really popular educational strategy that our peer caregivers appreciate is the use of mini graphic novels, and just wanted to share an example of one of those. In this situation, it's really focused on code of conduct. And in this scenario, a peer caregiver is going to retrieve commissary or canteen items for their patient. The patient suggests them picking up something for themselves. Certainly this happens in nursing homes and hospitals and all kinds of situations, patients wanting to give little presents to their healthcare providers. Not ever a good thing, and in corrections, particularly troubling because of issues of coercion and that sort of thing, financial abuse. And in the middle slot frames, which I did not include, the peer caregiver really has a dilemma about this. She's low on funds, thinking she could use some snacks, and then in the end makes the right decision and comes back to the patient and explains that she can't take gifts from her patients. Another such activity focused on who said it best. We focus a lot on effective communication and boundaries and those sorts of things. And here we give two different scenarios where the peer caregivers are describing the same situation, one more effectively than the other, and then they have to determine as a user who said it best. Testimonials of formerly incarcerated folks on loss, death, and bereavement experienced in prison has also been quite popular across both the corrections, health trainees, and the peer caregivers, and really nice compliment, I think, to our training. Just giving you an image of one of our staff module contributions. Here are some different challenges that can be faced by folks trying to start up a peer caregiver program, like lack of buyout from colleagues, lack of a support system to sustain peer caregivers if they've had a lot of patients die, or even one that's really important to them, peer caregiver burnout, which is why we focus on self-care. Just to highlight another parallel research arm we have right now, which we're doing research and development on computer-based learning to enhance Alzheimer's disease and related dementia in prison settings. which we've called Just Care for Dementia. Dementia is also a rising challenge in correctional settings, and there's actually something called prison activities of daily living that are assessed now. Are people able to get up and stand up for count and comply with a lot of the security demands that are placed upon them, so that and if they're not, and if there is a neurocognitive or some sort of dementia care unit available, which they are few and far between, they might be especially appropriate for that. So question 4 from the audience was, are there memory care units in prison? And the answer is absolutely, but not enough. And one of our advisory board members from California, Dr. Cheryl Steed, who's a clinical psychologist, was one of the founding members of the Gold Codes program, which is a peer caregiver program at the Men's Penal Colony in California, DOC. And I encourage you to watch her TED Med talk, and it's about an hour, 50 minutes or so long, but it is outstanding. I think it's from about 2016, and that program's still vibrant. Just shared some references with you if you're interested, and I think we're probably at time, so sorry for going a little long there.
Thank you, Susan. Yeah, we've got many comments and a couple of questions. I'm hoping that I can ask Eve to unmute and ask hers, and then we'll ask Jerry to do the same, and then we'll probably conclude. Eve, are you able to unmute and ask your question?
I am. Thank you. First of all, thank you so much for this presentation. I was just on a personal level wondering what your motivation and your path to caring for the special population was.
Excellent question. I was just sharing this with Marty before the session started. I actually started my nursing career as a licensed practical nurse, and was working in a small rural hospital in central Pennsylvania that serviced the care needs of 2 large state correctional institutions when their healthcare needs exceeded the capacity of the prison infirmary. So took care of a lot of patients who were incarcerated in the ICU and a step-down unit. Right when I was taking this first job as a licensed practical nurse, came back to Penn State and completed my baccalaureate and then a master's not long after, and took my students from Penn State back to that clinical site, and for years had them, as when I was a clinical instructor, taking care of folks who were incarcerated. And then later down the road, and a couple degrees later, ended up launching into this as my career program of research. So that's my story, and how I've evolved, I guess, over the past 30 some odd years.
And Jerry.
Hey, Marty. Hey, thank you so much. I'd echo everybody else, Susan, on great presentation. I wanted to say, I said that in the text, but thank you for calling attention to something that's very little known. Ironically, this technology thing that should help people in the facilities communicate. Capitalism has turned that around. But my question is, do the resources you provided help with, if you want to try to make a difference within a state's given correctional system, or is it pretty highly variable across the states?
Sure. We're still in the research and development stage. Our funding comes through something called Small Business Innovation Research Grants and Small Business Technology Transfer Grants with the NIH. And so typically there you see collaborations where you need to be partnered with a small business, which we are, with at some point down the road, we would intend to place this perhaps within CE or outreach or ag extension at a university, or partner with a correctional organization or some other such group, so that it could be sustained and commercialized, not for large money making, but just to be able to keep it up to date and the like. In terms of our more foundational research, first we had a large R01 where we did community participatory action research, or CBPR research, whatever terms you use, with 6 different state correctional institutions in PA. And back in those days, we were working with paper and electronic files and a library of resources. And we developed and disseminated those and did a train the trainer approach, much like LNAC, but on a smaller level. It was very research and time intensive, and there was nice uptake within that system, but it was not anything we could take on the road. And we realized back then, which was probably around 2009 to 2012, that more and more that the staff were being trained with computers. And so we saw this as an opportunity for potentially greater dissemination in the future. And so that's how we launched probably about 2015 into the computer-based training. Still in the R&D phase, we did get money from the NIH to have some market research done, and we're working with some folks from there right now, but no commercialization has occurred. But we do have early versions of our work that are, like I said, paper and electronic files and the like that were shared with those original PADOC 6 institutions, and also trickled out to others. And we've shared pretty freely with those materials. With this, we have some constraints on how we can share because of the notion of the NIH's intent that eventually it would be commercialized, so it could be sustainable and help small businesses as well. So hopefully that answers your question, Jerry.
All right. Susan, thank you. We appreciate your time today.
That's absolutely. It's been a pleasure. And, you know, I look forward to staying connected. Nice to see some new friends and see some names I'm familiar with from the past too. So you guys have a nice day and thank you.
All right, everybody. Have a wonderful weekend. Bye.